Okay, so now I'm going to talk about some of these medicines that manipulate the autonomic nervous system in order to get a therapeutic effect. Um, so we got alpha blockers, and they'll cause vasodilation. If you remember right, when we were talking over here, um, A1 caused vasoconstriction of peripheral vessels, right? So when you're blocking A1s, you're going to get vasodilation. That whenever you're getting an antagonist, it will block the effects that we talked about there. So A1 selective blockers, they usually end in osin, right? Prazosin, doxazosin, terazosin. These are all A1 antagonists or A1 alpha 1 blockers. So alpha blockers, they dilate blood vessels and decrease bladder sphincter tone. Some work more on blood vessels and some work more on bladder sphincter tone. So two different reasons that we take them. One is for blood pressure and one is for like an enlarged prostate where it's stimulating that sphincter to stay constricted all the time. So the alpha 1 selective blockers, and when we say alpha 1 selective, that means that they will block the alpha 1 portion, which will mean that they will have an effect on all of the things on here that I said were done by alpha 1, right? Alpha 1 pupil dilation, so they would cause pupil constriction. What else? Increased heart rate. That's betas, I'm sorry. Vasoconstriction, the vasoconstrict peripheral vessels, alpha 1. So we're going to cause vasodilation. Down here, relax the bladder and increase bladder sphincter tone. So you give an alpha 1 blocker, it will, instead of increasing the bladder sphincter tone, now we're blocking that, so we're going to decrease bladder sphincter tone. So the person will be able to pee if they weren't able to pee. And the thing about down here, the ejaculation and the erection, is that some of these medicines, if you are blocking some, it will have an effect on the person's ability to perform those activities. Meds that are more alpha 1 blockers that have more effect on the vessels are these: parazosin, doxazosin, terazosin. Alpha 1 blockers that have more effect on sphincter tone are tamsulosin, alfuzosin, and silodosin. So they're used to increase urinary flow and BPH. That's benign prostatic hypertension. Used to control hypertension, right? So these ones at the top that are more the prazosin, doxazosin, terazosin are used to control hypertension because they will cause vasodilation. So side effects are orthostatic hypotension and headache. Hopefully those make sense. Beta blockers will have a negative inotropic effect and decrease the heart rate. Negative inotropic effect, all that means is it will cause the heart to not beat so hard. Right? Inotropic is the force of contraction. So it's going to decrease the force of contraction and decrease the heart rate. That's what beta blockers will do. And that makes sense because if you look at, we're talking, if you look at what betas do, that's what they do. They increase the heart, so we're getting all the opposite effects. So first generation beta blockers are non-selective. They will block all of the beta stuff, right? So if you look at this, you're going to have a lot of effects here. They're going to bronchoconstrict. That's probably not good. If you're giving it for blood pressure, bronchoconstriction is probably something you don't really want to happen. But they are going to, this increases the heart rate, so they're going to decrease the heart rate. They're going to decrease the force of contraction. So the non-selective beta blockers are going to block all of the beta stuff. So if you look on that paper, anything that I said beta 1 or beta 2, it's going to go ahead and block those effects, and which means that you will get the opposite of what was listed on that other page. When we take a look at this, first generation, they're going to decrease the heart rate and contractile force. They're going to decrease oxygen demand on myocardium. They're used with hypertension. They're used for hypertension, angina, and tachyarrhythmias. By decreasing the rate and the force of contraction, you're going to decrease the blood pressure. By decreasing the rate and force of contraction, you're going to decrease the amount of oxygen the heart needs to beat. So you're going to decrease angina. Angina is the chest pain that you get when it's not getting enough blood supply for the amount of work that it's doing. So you're decreasing the oxygen demand, and you're decreasing the amount of angina. And it decreases the rate. So it's used to treat tachyarrhythmias. Arrhythmias that are tachyarrhythmias are fast arrhythmias. So it makes sense. You're slowing that down. First generation, these non-selective beta blockers, propranolol is one, and it crosses the blood-brain barrier, so it's often used for migraine headaches prevention. It prevents vasospasms of the cerebral vessels. And then you add propranolol, pindolol, nadolol, and timolol. They're used as, and timolol is used as an eye drop for glaucoma to decrease intraocular pressure. Okay, so now second generation beta blockers. Beta 1 or cardioselective, they'll often call these, because beta 1s, if you remember right back on that other page, beta 1s have to do with the heart. So beta 1 selectivity can vary from person to person. Also, the higher the dose, the more they will start blocking the beta 2s also. In other words, if they get higher and higher doses, they start losing their selectivity. So they won't affect just the beta 1s, they'll start selecting the beta 2s also. If you want the selectivity, you can't give a huge dose of it. Another thing is anytime that you have somebody who has asthma or COPD, you definitely don't want to give them the non-selective up here. But these down here, even given these, you have to do it carefully because like it says here, selectivity can vary from person to person and when the doses get higher. And how high the dose has to get depends on the person and for loss of selectivity. So you get so when you have somebody with asthma or something like that, you got to be careful in administering these medicines. A couple examples of beta 1 selective blockers are atenolol and metoprolol. Right, you see those out there quite a bit. Those are both very popular medications. Now, third generation. These guys are a little different because some third generation beta blockers are beta selective. Some third generation beta blockers are not beta selective, but what makes them third generation is that they have an added drug in them to cause vasodilation. So not only are you getting the cardiac effects of decreased contractile force and decreased heart rate, you're also getting vasodilation. So they're great for hypertension. As far as the third generation, some are beta 1 selective, some are non-selective. The unique thing about third generation is the blocker is that they have this added effect of vasodilation. Carvedilol and labetalol unselectively block beta receptors. These are third generations. They unselectively block beta receptors with an additional alpha-1 receptor blocker. So alpha-1s cause alpha-1 receptors, when stimulated, cause vasoconstriction, right? So when you block alpha-1s, you get vasodilation. So it decreases the heart rate and contractile force and causes vasodilation and side effect of bronchoconstriction. So you still get the bronchoconstriction because they're non-selective. So with carvedilol and labetalol, you can get the bronchoconstriction along with that. Now, if you come here, nebivolol selectively blocks beta 1, so you won't get the bronchoconstriction, but and it also, so nebivolol selectively blocks beta 1, and you get vasodilation by stimulating the endothelial cells to release nitric oxide. Nitric oxide is local endothelial vasodilator, right? And betaxolol is a beta 1 selective, and it has a calcium channel blocker added to it, which will cause vasodilation. So that's what your third generations are. You get the beta blocking, and you get vasodilation with it. Now, I just wanted to talk here a little bit about the beta agonists. Now, we've been talking so much so far, we've been talking all about beta blockers and alpha blockers, right? That means they're antagonists. Beta antagonist is a beta blocker. Alpha antagonist is an alpha blocker. Um, Now we're talking about agonists. Agonists, they do the opposite. They actually land on the receptor site and stimulate it. So they increase the effect. Instead of blocking the effect of the receptor, they increase the effect. So we have beta 2 agonists, but we don't have beta 2 blockers. We have beta 1 blockers, but not beta 2 blockers. I don't know why we would need beta 2 blockers. That's probably why we don't have them. But albuterol causes bronchodilation. Albuterol is a beta 2 agonist. And so what will it do? You take a look back here in this paper. Bronchodilation, beta 2, right? So we're not blocking beta 2s, we're stimulating beta 2s. And so by stimulating beta 2s, we are increasing the effect. So we're going to get bronchodilation. Beta 2 agonist will give us bronchodilation. Albuterol causes this bronchodilation because it's a beta 2 agonist. Also, the selectivity varies from person to person. And the more given, the more selectivity is lost. So it relieves dyspnea, side effects of tachycardia and jittery, because like if it's completely selective and it only stimulates the lungs, then you won't get that. But unfortunately, it's not completely selective. Nothing is completely selective, and everything varies from person to person. So when you give the albuterol, you can expect that person to get some tachycardia and some of the jittery feelings, right? Because that's the fight or flight. You're getting jittery, you're getting ready to go, right? You're getting ready to run, but there is no bear to run from. You're just laying there getting this breathing treatment. But it will stimulate that fight or flight to a certain extent. You're trying to stimulate only the lung portion of the fight or flight, but like I said, it will stimulate other areas. Xopenex is another beta 2 agonist. When Xopenex first came out, I remember the drug rep came to the hospital and told everybody that it was much more selective for beta 2 than what albuterol was. So you were going to have fewer side effects with it, less. So you're going to have less of the tachycardia and less of the jittery feeling, stuff like that. And that may be true, but they found out that for the price difference, and as long as you're giving albuterol in reasonable doses, and it's somebody a young person maybe, or somebody who can handle a little bit of tachycardia, it's just as good to just continue giving the albuterol. But they will go with Xopenex sometimes when they have somebody who has heart problems and they want to be extra careful not to cause a tachycardia. So now let's come down here to the anticholinergic drugs. Anticholinergic drugs. I'm only going to mention a couple now. Atropine. Got to mention atropine when we're talking about anticholinergics. Because atropine is used in several different medicines, mixed with different medicines to cause different effects, or to cause effects in different areas. Atropine blocks acetylcholine from activation from activation of some of the muscarinic receptors. Muscarinic receptors are some of the receptors of the parasympathetic. So atropine blocks acetylcholine from some muscarinic receptors. Used in several meds for different effects. It says is, but that's supposed to say in. Used in several meds for different effects. Atropine in eye drops can cause vasodilation. So when the acetylcholine stimulates the muscarinic receptor in the pupil, it causes pupil constriction. So we're blocking that now, and we're causing, that says vasodilation, it should be pupil dilation. So that's what they use in the eyes, right? They use that in the eyes, and the eye doctor wants to dilate your pupil so you can look in there. But anyway, atropine is an antidiarrheal medication, because remember, the rest and digest stimulates digestion and stimulates all that activity. Atropine blocks the acetylcholine from stimulating that stuff in rest and digest, so it will hopefully stop you from having diarrhea. Atropine is used in emergency situations to increase heart rate for patients with symptomatic bradycardia. So somebody comes in and they have a heart rate of like 40, and they're really, well, they don't have any energy and their eyes are rolling back in their head and stuff because they aren't doing any perfusing at that low rate. You can give them some atropine. Would be given IV. Side effects are dry mouth, which makes sense, right? Because acetylcholine causes the release of saliva, so side effects of atropine would be dry mouth, dry eyes, and constipation. All of those make sense if you look back at the other sheet. Ipratropium is used to block muscarinic receptors in the lungs by administered by inhalation. So ipratropium is used to block muscarinic receptors in the lungs and administered by inhalation. So they can inhale this stuff, right, and it blocks those receptors. And those receptors, remember in rest and digest, what happens to your bronchi? In rest and digest, your bronchi bronchoconstrict, right? Because it doesn't need all that air in it, so it constricts. You give ipratropium, it blocks the rest and digest effect by blocking the acetylcholine, right? Because it's an anticholinergic, so it blocks that, and by blocking that, you get bronchoconstriction. So blocks the parasympathetic nervous system effects of bronchoconstriction, which leads to bronchodilation, right? So you're blocking the bronchoconstriction and you get bronchodilation. Also decreases fluid mucus production in the airway, which also makes sense. Is also used in some nasal sprays to reduce rhinorrhea. So you can get this ipratropium in some nasal sprays too. And hopefully all of that makes sense.